Hello, everyone. So, once again, we're going to continue our discussion for the different problems under hematologic disorders. And we'll now proceed to sickle cell anemia. So, with regards to sickle cell anemia, it's a severe hemolytic anemia that results from inheritance of the sickle hemoglobin gene. So, this one is inherited by children. And this gene causes the hemoglobin molecule to be defective. So what happens here is that the sickle hemoglobin, HbS, acquires a crystal-like formation when exposed to low oxygen tension. So the oxygen level in the venous blood can be low enough to cause this change. Consequently, the RBC containing HBS loses its round, very pliable biconcave disc shape and becomes deformed, rigid, and sickle shaped. Remember, the disc shape of the RBCs allow the RBCs, together with the other blood components, to move freely within our blood vessels. But if they are deformed and become sickle shaped, there will be a hard time for the red blood cells to flow through the blood vessels, most especially to the smallest blood vessels like the capillaries. So these long, rigid RBCs can adhere to the endothelium of small vessels, most especially the capillaries, when they pile up against each other, and blood flow to a region or an organ may be reduced. So they are going to pile up within each other, block or occlude that blood vessel that's involved and restrict blood flow towards a tissue or an organ. So as you can see here from this illustration, some of the cells here appear sickle shaped, not the biconcave disc shape, which is the regular shape of our RBCs. So here you can see the difference between a normal red blood cell to a sickle celled RBC. So this is what I was explaining to you earlier. Most especially in the smaller blood vessels, this can occur. The sickle cell RBCs will block the blood flow if they clump onto each other in certain smaller blood vessels of the body. So, if ischemia or infarction occurs, the patient may have pain, swelling, and fever. And the sickling process takes time. If the RBC is again exposed to adequate amounts of oxygen when they travel to the pulmonary circulation, before the membrane becomes too rigid, it can revert back to its normal shape. For this reason, the sickling crises are intermittent. So it comes and goes. Cold can aggravate the sickling process because vasoconstriction slows down the blood flow. And oxygen delivery can be impaired by an increased blood viscosity with or without occlusion due to the adhesion of sickled cells. In this situation, the effects are seen in larger vessels, such as the arterioles, causing the sickling crisis to be intermittent. So the HBS gene is the one responsible for causing this disease, and it's inherited from people of African descent. So most especially those who are blacks, they are more susceptible to developing or to having this kind of disease, and to a lesser extent, people from the Middle East as well, the Mediterranean area. So that's in lower Europe and the Aboriginal tribes in India. Clinical manifestations, patients are always anemic, usually with a hemoglobin value of 7 to 10 grams per deciliter. Jaundice is a characteristic and is usually obvious in the sclerae. So that's in the white of our eyes. They become jaundiced. The bone marrow expands in childhood in a compensatory effort to offset the anemia, sometimes leading to the enlargement of the bones of the face and skull. And the chronic anemia is associated with tachycardia, cardiac murmurs, and often an enlarged heart or cardiomegaly. So this can happen due to chronic anemia. The body here is trying to compensate for the loss of oxygen, but the blood is the problem here, not the lungs. So what the blood is trying to do is to compensate for the loss of oxygen. It will try to increase the heart rate, causing tachycardia, cardiac murmurs to happen. Of course, if this takes or if this occur for a long period of time, tendency is the heart is going to be enlarged. So dysrhythmias and heart failure may occur once a child who is left untreated with this disease will proceed to adulthood. So as you can see here, this is the summary of complications seen in sickle cell anemia. Complications can occur in the spleen, the lungs, the CNS, the kidneys, the heart, bone, liver, skin and the peripheral vasculature, the eyes, and the penis among males. Um, just read this on your books because I got this from your Brunner and Siddhartha books. Now, one of the dangerous complications that the patient may have would be CVA or cerebral vascular accident or stroke due to the blockage of the blood vessels. That's one of the things that can occur. But primarily, one of the common complications seen in sickle cell anemia is autosplenectomy. When we say autosplenectomy, it means that the spleen will lose its function due to the limited blood flow towards the spleen because blood supply to the spleen will be cut off due to the sickling that is happening to the blood vessels going towards the spleen. So those things might happen, and it's very, very common. Signs and symptoms are here: abdominal pain, fever, signs of infection for autosplenectomy due to increased infection. It can lead to increased infection as well. But take note of the one in the lungs, the CNS, the heart, because that can proceed to heart failure. And one common occurrence that occurs in males would be priapism. Priapism is a condition wherein the penis or the whole penis of a male will remain erected for a long period of time. But take note, this is not a normal type of penile erection. That erection is accompanied by pain. As you can see here, one of its symptoms is pain. That is priapism. Yes, the penis stands erect for a long period of time, but pain can occur. Always remember the reason behind the erection of the penis is always our blood. Now, due to the sickling crisis, these sickled cells will block or occlude the veins of a male who has priapism. That's why the outflow of blood sometimes takes long to occur. So that happens in males. Just read on the rest. Sickle cell crisis. There are three types of sickle cell crisis in the adult population. The most common is the very painful sickle crisis, which results from tissue hypoxia and necrosis due to inadequate blood flow to a specific region of tissue or an organ. So that's what commonly happens due to the occlusion of the sickled cells inside the blood vessels going to a specific tissue or organ of the body. Aplastic crisis results from infection with the human parvovirus. The hemoglobin level falls rapidly and the bone marrow cannot compensate, as evidenced by the absence of reticulocytes. So this is one of the crises that are seen as well. And we have the sequestration crisis. With this results when other organs pull the sickled cells, Most common is the one in the spleen, the one I have explained earlier. The spleen is the most common organ responsible for sequestration in children, and by 10 years of age, most children with sickle cell anemia have had a splenic infarction. Why? One of the highly vascularized organs of the body is the spleen. So the spleen will no longer be functional, or that is the definition of autosplenectomy. So ectomy, it automatically is removed from the system due to the blockage of the blood vessels in the spleen. But in adults, the common organs involved in sequestration are the liver and more seriously the lungs, because these are highly vascularized organs. When we say sequestration, the sickled red blood cells are pooling inside it. They are crowding inside those highly vascularized organs. Assessment and clinical findings would be the patient with the sickle cell trait usually has a normal hemoglobin level, a normal hematocrit, and a normal blood smear. In contrast, the patient with sickle cell anemia has a low hematocrit and sickled cells on the smear. The diagnosis is confirmed by hemoglobin electrophoresis. It is a blood test used to measure and identify the different types of hemoglobin in our bloodstream. So, the confirmatory diagnosis of sickle cell anemia is hemoglobin electrophoresis. Take note, again, that is hemoglobin electrophoresis. Prognosis. Patients with sickle cell anemia are usually diagnosed in childhood because they become anemic in infancy and begin to have sickle cell crisis at around 1 to 2 years of age. And some children die in the first years of life, typically from infection, but the use of antibiotics and parent teaching have greatly improved the outcomes for these children. However, with current management strategies, the average life is still suboptimal. As you can see here, the average life expectancy of children or people with sickle cell anemia is at 42 years of age, which is very low for the standards that we have today for the life expectancy. In some patients, the symptoms of and complications diminish by 30 years of age, and these patients may live into the sixth decade of life or longer. So some of them can be fortunate enough to be 60 or more in age. Medical management is by administering a chemotherapeutic agent known as hydroxyurea or hydrea, which has shown to be effective in increasing the hemoglobin F levels in patients with sickle cell anemia, thereby decreasing the permanent formation of sickle cells. Side effects of these drugs include chronic suppression of the WBCs, teratogenesis, and potential for later development of a malignancy. So we need to teach patients again about um, precautions due to the suppression of WBCs. So again, avoid going to crowded places, avoid people with infection, always do hand washing, and so on. Chronic transfusions of RBCs have shown to be highly effective in several situations in an acute exacerbation of anemia, such as a plastic crisis, also in the prevention of severe complication from anesthesia and surgery, and in improving the response to infection when it results in exacerbated anemia. Patients with sickle cell anemia require daily folic acid replacements as well, like in folic acid deficiency, to maintain the supply required for increasing the erythropoiesis from hemolysis. And if the patient is experiencing infections, they should be promptly treated with different types of antibiotics because infection remains a major cause of death among these patients. So that's why patients of sickle cell anemia needs to be taught well with regards to the avoidance of infection. They should always wear mask at all times. Hand washing is very, very important. What else? The avoidance of eating raw foods as well. Those are the things that we can teach these patients. NSAIDs such as aspirin is given to relieve the patient from pain, and it will relieve the patient from potential thrombosis. Nursing management. Pain management, of course, is very, very important. So we need to administer NSAIDs, teach them relaxation techniques and breathing exercises, most especially deep breathing exercises, and prevent the occurrence of infection by giving appropriate antibiotics. Provide the patient with opportunities to make decisions about daily care. This may increase the patient's feelings of control. So we promote independence with their activities of daily living. We are not going to do everything for the patient. They should do it on their own because this will help also their general mental well-being. And monitor the patient or monitor and manage the potential complications such as leg ulcers. Priapism can lead to impotence. So prolonged erection of the penis is not good because that can lead to impotence later on, and chronic pain and substance abuse. Most likely narcotics because they may abuse narcotics due to the constant pain that they are going to feel. Okay, so now we go to thalassemia. What is thalassemia? These are a group of hereditary disorders associated with the defective hemoglobin chain synthesis. So this is with regards to the production of hemoglobin. So these anemias occur worldwide, but they are highest in prevalence in the Mediterranean, African, and Southeast Asian ancestry. So take note, Southeast Asia. We are in the Southeast Asia. Thalassemias are characterized by hypochromia, meaning there's an abnormal decrease in the hemoglobin content of our RBCs. Extreme microcytosis, so smaller than usual RBCs, and the destruction of blood elements, hemolysis, and variable degrees of anemia. In thalassemia, the production of one or more globulin chains within the hemoglobin molecule is reduced. When this occurs, the imbalance in the configuration of the hemoglobin causes it to precipitate in the erythroid precursors or the RBCs themselves. This increases the rigidity of the RBCs and thus the premature destruction of these cells. So what happens here is the 120 lifespan of RBCs are lessened to its normal lifespan. And there are types of thalassemia. We have alpha thalassemia. These type of thalassemias mainly occur from Asia and in the Middle East. The alpha thalassemias are milder, but the beta forms and are milder than the beta forms, and they often occur without symptoms. The ARBCs are extremely microcytic, but the anemia, if present, is mild. Beta thalassemia, however, is the worst one. They occur and they're more prevalent in the Mediterranean population, but also occur in people in the Middle East or Asia. The severity of beta thalassemia varies depending on the extent to which the hemoglobin chains are affected. If left untreated, severe beta thalassemia, such as thalassemia major or Cooley's anemia, can be fatal within the first few years of life. If it is treated with regular transfusion of RBCs, sadly, patients still may survive only up to their 20s or 30s. So their lifespan is very short. So as you can see here, this is the normal red blood cells, but for thalassemia, they appear abnormal. They are abnormally shaped. So normal red blood cells, and we have the red blood cells here in beta thalassemia major under the microscope. So you can see here they are They appear in variety of shapes: poikilocytosis in sizes, anisocytosis, and they are very pale. Inheritance of thalassemia: both parents should be a carrier, and there is a 50% chance of children to be a carrier of the disease, while there's a 25% chance that one of their child will have the disease, and a 25% chance of a having a healthy child. So those are the odds of having thalassemia. Thalassemia major or Cooley's anemia is characterized by severe anemia, marked hemolysis, and effective erythropoiesis, which is the production of RBCs. With regular transfusion therapy, growth and development through childhood are facilitated. Organ dysfunction due to iron overload results from excessive amounts of iron obtained through RBC transfusion. So, this can be one of the effects of long time use of blood transfusion. Iron overload can occur. Regular chelation therapy via the administration of subcutaneous deferoxamine has reduced the complications of iron overload and prolonged the life of these patients. This disease is potentially curable by BMT or bone marrow transplantation if the procedure can be performed before the damage to the liver occurs, most especially if this is done during childhood. So, this should be determined or diagnosed as early as possible in order to perform bone marrow transplantation as soon as possible. So that's it for thalassemia. Now we go to glucose 6 phosphate dehydrogenase deficiency. Take note, this is one of the conditions that are being detected on newborn screening, G6PD deficiency. Aside from this, there are other diseases diagnosed or determined through newborn screening. What are they? We have PKU or phenylketonuria. We also have congenital adrenal hyperplasia. We have congenital hypothyroidism and maple syrup urine disease, MSUD. So these are the different diseases that are detected through newborn screening, including this one, G6PD deficiency. This is an abnormality in the G6PD gene. So this gene produces an enzyme within the RBC that is essential for membrane stability. A few patients have inherited an enzyme so defective that they have a chronic hemolytic anemia. However, the most common type of defect results in hemolysis only when the RBCs are stressed by certain situations. So there are triggering factors in this disease. This disease will only appear if there is a triggering factor, which I am going to explain later. So, infection or fever or certain use of medications can cause G6PD disease to occur. So, this type of deficiency is found again in the Mediterranean population, and it's more severe than that of the African Caribbean population, resulting in greater hemolysis and sometimes life threatening anemia. All types of G6PD deficiency are inherited as X linked defects. Therefore, more men are affected or are affected and are at risk than women. Medications that have hemolytic effects for people with G6PD deficiency. So these are the different types of medication that can trigger this disease. What are they? We have anti-malarial agents such as chloroquine, sulfonamides, which are which is a type of antibiotic. Nitrofurantoin. We also have analgesics, including aspirin, if given in high doses. Thiazide diuretics, such as hydrochlorothiazide, chlorothiazide, oral hypoglycemic agents, such as glyburide, metformin, chloramphenicol, vitamin K supplementation, and certain foods such as fava beans can trigger it. What are the clinical manifestations of G6PD deficiency? Patients are asymptomatic and have normal hemoglobin levels and reticulocyte counts most of the time. However, if it has been triggered by what? By an offending medication, those drugs that I have mentioned earlier, they may develop pallor, jaundice, and hemoglobinuria or hemoglobin in the urine. The reticulocyte count rises and symptoms of hemolysis develop. Special stains of the peripheral blood may then disclose Heinz bodies. These are degraded hemoglobin within the RBCs. Hemolysis is often mild and self-limited. However, in the more severe Mediterranean type of G6PD deficiency, spontaneous recovery may not occur and transfusions may be necessary. So as you can see here, these are the Heinz bodies seen on the RBCs of patients with G6PD deficiency. Assessment and diagnostic finding. This is diagnosed through newborn screening. So hopefully if you have children of your own later on, all of these diseases under newborn screening will appear negative. Medical management. The treatment is to stop the offending medication. Transfusion is only necessary only in severe hemolytic states, which is more commonly seen in the Mediterranean variety of G6PD deficiency. So that's it. That's how they treat G6PD deficiency. They will appear normal unless they are given those offending medications. So take note of those medications that might trigger G6PD deficiency in a patient. Nursing management, we should teach the patients about the disease and give that list that I have given you. Give a list of medications to avoid. If hemolysis does develop, nursing interventions are the same as for hemolysis from other causes. Now we go to polycythemia vera. What is it? Polycythemia vera, or primary polycythemia, is a proliferative disorder in which the myeloid stem cells seem to have escaped normal control mechanisms. So the bone marrow here is hypercellular, and the RBCs, WBCs, platelet counts in the peripheral blood cells or peripheral blood are elevated. So all of the blood components are elevated. But the most predominant blood cell are the RBCs, because if they are elevated, the hematocrit can exceed 60%. So imagine it, it's 60%. This phase can last for an extended period, 10 years or longer. And the spleen resumes its embryonic function of hematopoiesis and enlarges. Over time, the bone marrow may become fibrotic, with the resultant inability to produce as many cells as possible. So the bone marrow will experience burnout later on if this happens. So the disease evolves into myeloid metaplasia with myelofibrosis or AML in a significant proportion of patients. This form of AML is usually refractory to standard treatments. And median survival time for patients who have polycythemia vera exceeds 15 years. So it's averaging at that age. Clinical manifestation, patients typically have a ruddy complexion and have splenomegaly, enlarged spleen. Symptoms include the following due to the increased blood volume: headache, dizziness, tinnitus, Fatigue, paresthesias, or the tingling sensation of the extremities. Blurred vision can also be experienced by the patient, or from increased blood viscosity, they might experience angina. Claudication, I have already explained to you claudication before in the peripheral vascular diseases. Dyspnea and thrombophlebitis, particularly if the patient has atherosclerotic blood vessels as well. Another common and bothersome problem is generalized pruritus. So they will experience itchiness due to the histamine release from the increased number of basophils. Remember, basophils are mast cells that are secreting these chemicals that are needed during an allergic reaction. Erythromelalgia, which is the burning sensation in the fingers and toes, may be reported and is partially relieved by cooling. So take note, erythromelalgia is the burning sensation in the fingers and toes. This is very different from the tingling sensation, which is paresthesias. Assessment and diagnostic findings. Diagnosis is made by finding an elevated RBC mass, a nuclear medicine procedure, and a normal oxygen saturation level and an enlarged spleen. Other factors useful in establishing the diagnosis include elevated WBC and platelet counts. And the erythropoietin level is not as low as would be expected with an elevated hematocrit. It is normal or only slightly low. Complications of polycythemia vera is that they are, or patients who have this are at increased risk for thromboses or blood clots, which might result into CVA or cerebrovascular accident. That's stroke, because blood clots can occur inside their brain, or MI, myocardial infarction. Thrombotic complications are the most common or most frequent cause of death among patients who have polycythemia vera due to the increase in the number also of platelets. Bleeding is also a complication, possibly due to the fact that the platelets are often very large and are somewhat dysfunctional later on. Bleeding can be significant and can occur in the form of nosebleeds, ulcers, and frank gastrointestinal bleeding. What are the medical management? Phlebotomy is an important part of therapy and can be performed repeatedly to keep the hematocrit within the normal range. How is this done? They are going to remove the excessive blood from the patient. This is achieved by removing enough blood, around 500 ml, once or twice weekly to deplete the patient's iron stores, therefore rendering the patient iron deficient and consequently unable to continue to manufacture RBCs excessively. So, to keep up with the loss of iron due to the phlebotomy, patients will be instructed to take or to avoid iron supplements, including within those with multivitamin supplements. If the patient has an elevated uric acid concentration, allopurinol is used to prevent gouty attacks. If the patient develops ischemic symptoms, dipyridamole is sometimes used. Radioactive phosphorus 32P or chemotherapeutic agents such as hydroxyurea again can be used to suppress bone marrow, but they may increase the risk for leukemia. Other medical management, aspirin is also used in diminishing pain associated with erythromelalgia, which is the burning sensation felt. Anagrelide, agrelin, inhibits platelet aggregation and can be useful in controlling the thrombocytosis associated with polycythemia vera. So it's either thrombocytosis can occur, or the thrombocytes later on can be non-functional, leading to bleeding. The consequences of having thrombocytosis is for the abnormal blood clots to occur in the blood vessels, causing CVA or MI. Nursing management, our role here is primarily an educator. Risk factors for thrombotic complications should be assessed, and patients should be instructed regarding the signs and symptoms of thrombosis. Patients with a history of bleeding are usually advised to avoid aspirin or aspirin containing medications because these medications can alter platelet function. This will make the patient further bleed if they have bleeding signs and symptoms. So make sure to avoid medications that will cause the patient to further bleed. Minimizing alcohol intake should also be emphasized to further diminish any risk for bleeding. If the patient is experiencing pruritus due to the increased number of basophils, the nurse may recommend bathing the patient in tepid or cool water along with applications of cocoa butter-based lotions and bath products. So that's it for for polycythemia vera. Before we proceed to hemophilia, I need you to understand the intrinsic and extrinsic factors associated to blood clots. So there are different factors that are needed in blood clotting. It's from factor 1 to factor 13. Now, the one I'm showing you here is a cascade in order to form a stable fibrin clot, a stable blood clot. If you remove all of these factors, or any rather of these factors for blood clots, do you think blood clot is going to occur? This is a chain reaction in blood clots. If I remove one of it, of course, I'm removing one essential component of blood clotting, which are the clotting factors. Blood clot is not going to occur. And this is one of the problems associated with hemophilia because they may be missing one of the clotting factors that I am showing you here. If they miss one, or if they lack rather one of any of these clotting factors, then that would be a huge problem for them. Huge problem in forming blood clots if they have experienced any cuts or injury that may cause them to bleed. So we now proceed to hemophilia. So in hemophilia, it's a defect in clotting mechanisms of the blood, genetic disorder. Again, it's X-linked. So it's usually occurring in males. Females are carrier in X-linked, but the males are the ones who are going to manifest the disease. And there are classifications. We have factor 8 deficiency, which is the classic hemophilia. It's also known as hemophilia A. And factor 9 deficiency, known as the Christmas disease. Because as you can see here from this table, factor 9 is known as the Christmas factor. That's the name of the factor. That's why it's also termed as the Christmas disease or also the hemophilia B. Clinical manifestations or clinical findings, there's a prolonged bleeding from any wound. So if they have cuts, if they have any wounds, bleeding will be prolonged, and bleeding into the joints may occur, also known as hemarthrosis, resulting in pain, deformity, and retarded growth in children. There can also be intracranial hemorrhage if there's injury to the head. Severity of bleeding. There's three types: mild, factor 8 activities 5 to 50%. They will only bleed with severe trauma or surgery. For moderate, factor 8 activities 1 to 5%. They will bleed with trauma. So if they get an injury, that's the time they're going to bleed. Unlike that of mild, only severe trauma can cause bleeding. But for the severe type, factor 8 activity is only at 1%. And they can have spontaneous bleeding even without trauma. So Even if they haven't experienced trauma, you can see that their arms, their legs might have hematomas, even even though the trauma hasn't occurred, or even though they didn't get hurt from anything. Treatment is to control the bleeding. Prevention of bleeding with use of factor replacement because they lack those factors. Factor A for classic hemophilia or hemophilia type A, and factor 9 for hemophilia B or the Christmas disease. So we are going to infuse factor 8 concentrate from recombinant DNA. But if they have, that's for hemophilia A. But for hemophilia B, factor 9 complex will be given, which also contains factor 2, 7, 9, and 10. So this is concentrated. Adjunctive measures, aminocaproic acid, Amicar, inhibits the enzyme that destroys formed fibrin and increases fibrinogen activity in clot factors, or clot formation rather. Fibrinogen will also be given to maintain plasma fibrinogen levels required for clotting materials. Thrombin will be given, which supplies physiologic levels of natural material at superficial bleeding sites to control the patient's bleeding. Now, nursing management. We advise the patient to watch out for signs of bleeding. Aside from that, the very, very important patient teaching that we are going to include are the following. Avoid using sharp objects. So take note, we are going to tell the parents of a child who has hemophilia, because this is a childhood disease, to not let their children do any household chores that will make them handle any sharp objects, such as chopping, skinning potatoes, doing kitchen work, because kitchen work requires the usage of knives, of sharp objects. They should wear shoes at all times. They should avoid going barefooted, because who knows, they might step on a shard of glass or a thumbtack. Avoid contact sports. They shouldn't play baseball, football, basketball, volleyball, or any other type of contact sports. Most especially, of course, martial arts like karate, taekwondo, kung fu, judo, aikido, and so on. Because contacts, they might experience trauma from these contact sports and they might bleed from it. And they should use electric razors instead, because the use of um, razor blades can cause them to have cuts here on their face if they shave. An electric razor is very, very useful for them. Cut nails across. So teach them how to cut their nails in just a straight line like this. A straight line only. They shouldn't cut the peripheral nails or the peripheral portion of the nails, because that will put them at risk of having cuts and they're going to bleed. And in order for them to avoid gum bleeding, they should use a soft bristled toothbrush. They shouldn't buy the cheap toothbrushes that are being sold out there, because those toothbrushes are hard. They should use a soft bristled one. So that's it. Thank you very much for listening to our topic for hematology, and good luck to your upcoming examinations. Again, I thank you very, very much for listening to all of my lectures under cardiology and hematology. I hope you have enjoyed our time for the lectures that I have provided you. And thank you again very much. Good luck to all of you third years in your medical surgical examinations and your other subjects as well. And let's hope to see you again next semester. Again, this is me, JV De Guzman. I wish you all the best in your endeavors in this nursing course. Have a great day to all of you. And have a great sem break as well after the exams. Thank you and goodbye.